thanks to Linda and the Coalition for having me today. I'm happy to speak about the newly established HRSA Black Lung Center of Excellence. And for those of you who don't know who HRSA is or what we do, we've sort of been the redhead stepchild of the program for many years, and in the last couple of years have taken an increased role, active role in the program. We are the funding agency for the clinics. We receive our authorization from Congress. The Black Lung Clinics program is a direct line item in our budget. So we fund 15 grantees of record across the country to serve coal miners and their families. And the clinics provide screening, diagnosis, and treatment for coal miners and their compensation counseling for the families as well. HRSA sees the Black Lung Center of Excellence as an important aspect of responding to an increased focus of program integrity and aligning with authorizing legislation and regulations, as we have been charged to do across all programs in the last couple of years. And we're excited about the opportunity to provide grantees with technical assistance to strengthen the focus on performance management and quality improvement, and expand the medical community's knowledge of Black lung and co-workers' pneumoconiosis. We will be working with the University of Illinois at Chicago, who is partnering with National Jewish Health in Denver, Colorado, to provide the technical assistance. And why is this Center of Excellence important, and why now? Because we understand that the program has received level funding for way too many years, in spite of the increase in coal workers' pneumoconiosis and other coal mine dust lung diseases, and we see an increased need for there to be focus on these issues. We want to be able to answer the question, what difference are the clinics making with regard to identifying coal mine dust lung diseases in miners, reducing their prevalence, and meeting the needs of coal miners and their families through the provision of quality testing and services. This information is particularly important because this is information that we feed back to the Secretary of Health and Human Services. And several people have mentioned the bureaucracy and the red tape of the federal government. And once that information is provided to the Secretary, that goes into the President's budget proposal and is ultimately given to Congress for them to make decisions on the funding levels for the program. In the last several years, we've had an opportunity to look at the data in the program, and one of the reasons that I'm not overloading you with statistics this morning is because what we've realized is that the data we've collected up to this point has given us a lot of information about the volume of services that the clinics provide. And while that's important, we believe of greater importance is to look at both the quality of services provided and the difference that these services make in the lives of miners and their families. So we've had little information of that to pass on to Congress and to others who may be interested. So that's why we're hoping in the next several years to move in that direction. Why is this important to you, and what does it mean for all the clinics? It means several things. First of all, this Center of Excellence will help us move in that direction. It also means that the clinics will have ongoing technical assistance, formal technical assistance through HRSA, the Health Resources and Services Administration, and our office, the Office of Rural Health Policy, which oversees the program. It means that technical assistance may include things like periodically reviewing test results, spirometry, and X-ray results to evaluate quality. It also means working with clinic personnel to ensure they're properly trained, especially if they're new to the program, as there's often staff turnover. And it means that we'll be looking at ways to enhance education and outreach across all the clinics. It also means that we're going to be looking to the clinic staff and to all of you to provide as much input as possible into any standards that are developed and any data is collected. As you know, I am not the final decision maker, so it will have to go through multiple levels of clearance, but we will work with the Center of Excellence. Ultimately, the decision will be made by HRSA and senior staff at HRSA, as well as HHS. We hope to be able to collect meaningful data on minors and the services that you all provide. And over the next year or so, we'll be putting something in place that will help us better understand the quality of services provided and the health status of minors. And Dr. Cohen, to join me in case you have particular questions for him as well. Any questions? No questions? I find that hard to believe. Sure.
Well, I'll just stand here. I just wanted to thank Nadia and HRSA for awarding us the Center of Excellence. We've been working really hard in this area for a long time, and I think that we can help provide, really what we're going to hopefully do is provide expert consultation to HRSA, and then also be available to the rest of the clinics to help train your new providers or provide assistance with protocols, and also helping you review your testing and the quality of the work that you're doing. And it really coincides with a lot of the work that we're doing in our research plan, which is our Alpha Foundation research, where we're looking at data, and we noticed that the actual clinical data that comes from the clinics is not as helpful to really understand the population as a whole. And I think that in terms of us fighting for more funding as a clinic, if we can get really good data to HRSA, I think that'll help us get better funding. We've been talking about that for years, but just haven't been able to get it enacted across the country. And one of the problems in this last funding cycle for all of the grants was the total amount of money for all the clinics is just was certainly 70% or less than what we really needed as a group. And everybody, including University of Illinois, not any problem with Nadia at all, but we all suffered from not getting the funding that we all need. And I think if we can really organize a way to get clinical data, one, will understand the population better to hopefully provide better treatment interventions and services, but also then to advocate with Congress for better funding. So we really felt like we could not handle the entire country, so we were partnering with Cecile Rose at National Jewish. So she'll be, and her group and her shop at National Jewish will be providing the assistance out west that's needed for, we have a new clinic, Arizona has a new clinic. Are they here, the Arizona people? I don't know if they made it to the...
No, they did not.
Oh, okay, I was going to welcome them to the family, but so that will be available also, and she was unfortunately not able to come. She's speaking at a NIOSH Western meeting today, but sends her regards. But that's all from my point of view. We hope that we can be here to help, and and I think it will be. Hopefully, we can continue to help in a little bit more official way than I think we've done a lot of this for years. But we'll do the same.
So just two things I wanted to add. One is that we will hope to expand our collaboration with both NIOSH and DOL. I know there's been some mention of that, and I just want to say that we are ready and willing to work with you both to the degree that we're able and can be helpful. And there was a rumor floating around that I'm leaving, and that's not at all true. So just want to confirm that I'm going to be here a while. So thank you.
We do have a question. Anita?
I think I have a big enough mouth. I don't need the microphone. I have a question for Nadia and maybe anybody in the room that can answer this for me, because it's been posed to me and I don't really answer to it. Every year that I've been here, and again tomorrow, I'll be making a plea for all of the HRSA clinics to also go through the NIOSH approval process to become a NIOSH approved clinic to do surveillance for data that will come into NIOSH. One of the questions that recently has come up a lot is if a HRSA clinic becomes approved by NIOSH, do they have to stick to their region that their clinic is in? Or can they provide surveillance for NIOSH for anywhere in the United States? If they have a mobile unit, or if, say, we have our unit in Wyoming and we tell a minor to go to a HRSA clinic, can he go anywhere, or do they have to stick to their area?
So I would have to see how the funding was distributed in that regard. Unfortunately, because our clinics are, we just don't have as much funding as we would like to give to all the clinics, and so we have to be careful on how those dollars are used according to our regulations. So I would need to have a further discussion with the clinic and see sort of how that would be worked out. So I'm not going to say yes or no at this point.
Okay, what we're running into is under the new dust regs, especially in Oklahoma, Louisiana, and Texas, there are no clinics, period. And, I've been kind of trying to encourage a lot of the clinics in the West to provide some coverage there. But so far we don't have any, and we're having to rely on some contracted mobile units that aren't HRSA funded to go into those areas. And that's just an area I'd like you to think about, because as you'll see tomorrow when I give my presentation, when we were there with our mobile, it's like you're speaking a foreign language in those areas. So black lung is not in their vocabulary.
Sure, and that's something I'd be happy to discuss offline, and we can certainly come up with guidance to the clinics. But I think I'm the low man on the totem pole in this regard, and so I would just want to run it by our grants management staff as well as senior staff to see what their perspective is as well. Thank you.
Okay, Dr. Forehand.
With regards to your funding, can you convince Congress and the granting agencies of the presence of severity of disease by using data acquired from non-HRSA funded clinics such as DOL and CIMS?
Of course, we use any data that we have access to. And so when we report to Congress or when we respond to congressional inquiries, we use any data that we have, although our first source is HRSA clinics and the data that we've collected, which is why we're moving toward collecting patient-level data from the clinics. And we'll be moving in that direction going forward. So, does that help?
It's just a reminder that other data is out there.
And I understand from our perspective, though many of the questions that we get are related to the services that the clinics provide from a medical clinical perspective.
Okay. Roger?
Is your program responsible for training the non-clinic providers, or is that something that you do in another capacity?
The non-clinic?
Yeah, the non-clinic people who examine, who do the initial DOL exams.
Well, glad you asked that question, Roger. We're working in another capacity with the U.S. Department of Labor, OWCP, to develop training modules for the 413B examiners.
So that's a separate.
And that's a separate issue, but what's wonderful about it is that a lot of that material can be used to train clinic providers. It'll be public. The DOL is going to have it, I think, available on websites, and so it's really there's a lot of crossover. It doesn't handle treatment as much, but it's almost, what we're developing is really for diagnosis. So the treatment parts of what the clinics do would be something we would do more through the centers of excellence. But the diagnostic part of it is really, there's a lot of crossover, I think. Is that fair to say, Jerry? Is it? Okay.
Well, then I'll comment on one of the things I've seen recently. I'm spoiled because most of my work, the initial provider is Don Rasmussen, of course, and that's, the gold standard for anybody who's had that fortune. But I've had some recent experiences with people who've come to me after their exams, and I've seen some pretty uninformed medical opinions coming out of that. So for any way this program or anyone else can deal with it, I'd like to see some better training for those doctors because I think they would reach out for it.
Can I mention just a few things about the training that we're doing? Is that yeah? So we had a meeting in Pipestem. I don't know if you were there, Roger. In June, we had a 3-hour workshop where we called it an incubator workshop to develop what we thought would be good components of the curriculum. We're moving forward now, adding video. So actually, Don was gracious enough. He spent this past Monday with the Mine Academy videographers. They videotaped an entire exam and intake and PFTs and exercise studies. So we're going to edit that video and make it part of 4 one-hour modules that will give the docs 4 hours of CME credit. I don't know how the DOL is going to do it, but they're going to sort of encourage them in some way to take that. Maybe they can even encourage them to the point of not allowing them to be on the list if they don't take it. I don't know how that's going to work out, but that's up to them administratively. But it'll be available as CME accredited for them to take. And then we'll also, I think, continue to offer workshops through these types of conferences so that if the 413B examiners can be encouraged to come, they can have more face-to-face training. So that's at least an attempt to, so they at least can't say they didn't know what the right way to do things is. It doesn't necessarily mean they'll do the right thing, but I think that should be very helpful, I hope. And it'll be peer-reviewed by NIOSH as well, so this is not just a University of Illinois project. We're developing the material. NIOSH will peer review it, and then the DOL will either approve it or adopt it as they see fit. But I think it should be something helpful.